This is the DocNation Podcast. We are a movement founded by doctors, for doctors, dedicated to empowering medical professionals to reclaim control over healthcare decisions and advocating for their fair share of the industry's resources. Please note, the views expressed are those of DocNation and not necessarily those of our guests or referenced health centers.
Hey, Paul, good to have you. I just want to start by clarifying exactly what DocNation does and why we exist. We exist to do two things. There's a philanthropy side where we are starting a union. We're creating a union to get back the power to the physicians, to keep it very simple. And then the other side is to represent physicians individually, just like a sports team or just like an athlete, professional athlete has an agent. That's what we do for physicians. So to keep it very simple, but without further ado, Paul, would you introduce yourself and tell us a little more about you?
Sure. Hi, everybody. Thanks for having me on your show. My name is Paul Morton. I'm a board-certified orthopedic surgeon in Honolulu, Hawaii, which is where I was born and raised. And I left for medical school, for residency training and fellowship training. But ultimately, I came back home. And the practice environment, I think, is fairly different than some of what you might be seeing on the mainland. So it's just an interesting comparison.
So one of the things we were talking about before we started recording was about the decision making, and because in our prior conversations, Paul, we were discussing the difference between being in private practice versus being employed, and how there's so many other parties that are calling the shots with how healthcare should be provided, and patients are in a lurch because they're trying to figure out, with healthcare not going the direction that it should be going, who's to blame. And unfortunately, the doctor is the one that gets the finger pointed at, kind of, sort of, because that's their best connection to what healthcare is. And they don't realize that there's so many other people that are behind the scenes, kind of like pulling the strings on what should be happening. It's like, wait a second, the doctor, they're on strings? Like, how's that even possible? 40 years ago, that was never a thing. So talk to our viewers about what your perspective is in terms of making some of your own decisions, because you have leadership, you have decision-making ability in part of your life, but then the other part, you also have to work with other groups where they are in control, and give a little bit of a insight into what it's like from a day-to-day on how all that works together.
So my practice is relatively interesting. I am on one side a solo practice orthopedic surgeon. About 50% of my time I spend in Honolulu, a little bit over 50% of my time I spend in Honolulu, where I am, primarily in charge of, what I do for my practice. I get to choose which hospital I want to go to and negotiate with and bring my cases to. And then about 40% of my time I'm on the Big Island, which is a neighbor island, where I'm a 1099 contractor, which essentially, for all intents and purposes, makes me an employee of a medium-sized organization there. And I think there's a lot of pros and cons to both. I mean, the employed world, I essentially get the comfort of not having to worry about making decisions and who my staff is. But on the flip side, when I'm private practice, I make all of my own decisions in terms of where I am and which hospital I get to go to. And I think there's a lot of things that are really interesting, in terms of choices of vendors. We live in a world where the hospitals are trying to cut costs, and usually this is in terms of making profit for the hospital. And so the hospitals will choose which vendors or which systems that they want to use. And some of the hospitals, some of their employees are consultants for some of these companies. And so you notice that there's a tie between the medical director of orthopedics and the consulting firm the consulting agreement that they have, and their the types of equipment you're allowed to use at that hospital. And so it's a very interesting world in medicine that we live in, where we really don't have much control over what we're choosing anymore.
Don't have control over
That's
what you're
weird.
choosing anymore.
Well, so let me give you an example.
It's like, did you just walk? Yeah, let me give you a little bit of an example. Just a real life, easy to understand example. You know, the World Series just ended. And just think if those baseball players couldn't choose their own glove or their own
Right.
bat or their own cleats, things that the tools that they have to have to perform at a high level, every one of them would be making an excuse. Of course, I didn't play well. I couldn't get the glove I needed. The glove doesn't fit. It's not the right glove for the position. It's the same thing for physicians. You're not making decisions. You are a pawn in a giant game, and they are pushing you around and putting you right where they want you to be. And it's difficult. It's difficult.
Well, so I mean, that's definitely true. I mean, a lot of times, like in Honolulu, the hospitals have all decided to go either dual vendor or single vendor or dual vendor for their joint replacement implant companies. And this dual vendor means, they can, if you go to that hospital, you can choose one of two implant companies to use. You can use, there's four big ones, which is, Zimmer, DePuy, Stryker, and Smith and Nephew. And then there's a few medium-sized ones and smaller ones. But at certain hospitals, you really can only choose two of those. And some of those, sometimes, some of the medium-sized hospitals in Hawaii, you can't even choose one of the top three. You have to choose something out of, a second or third tier orthopedic company, which is kind of interesting when you're trying to look for specialty equipment, or you want to just do something as simple as changing a plastic component. They have to negotiate on pricing of the equipment, even for a large vendor company. And so you're kind of stuck with waiting for hospital contracting in order to just do sometimes even just what would be considered a simple case in that hospital.
And for the patient who is listening, or your fellow surgeons that maybe aren't having to deal with this, having to have the second, third, fourth, fifth option, what is that a big deal? Does that matter to the quality of care that the patient could receive, or to your ability to do what you're trying to do for the patient? How much of help us understand the gravity of you're having your hands tied like this?
So I'll give you a great example. I'm very comfortable with one system. I've gone around and used a bunch of different robotic systems on the market, from all four of those top companies. And with one of them in my hands, I'm much more efficient. And some of the other systems take me about twice as much time in order to perform the surgery. And what I tell people is that, time under the knife and time open puts you at risk for things like infection.
Yeah.
And so you want to be efficient in the operating room. You don't want to necessarily be rushed or fast, but you always want to be efficient. And if you're efficient, ultimately there's less time for your surgery. And the less time you're under the knife, the better the outcome. Right. And it's actually less expensive for the hospital. But because the cost of it, which associated with time, is an indirect measured expense, the hospitals will more likely choose something that may be less expensive on when they negotiate for pricing. Whereas in my hands, it may be something that ultimately would have been less expensive for the hospital, for the patient, and less risky for the patient.
Contracting, administration getting in the way, doubling the time it takes to do a procedure.
Is it possible to talk about this? Because I was researching, we discussed that white paper by Dr. Charles DeCook, the 12 by 12, the radical time transparency stuff, as we were talking about biotech and AI in the OR.
Yes.
One of the sections in there talks about I can't remember how much time it was, but once you get beyond a certain amount of time, the infection risk just starts to increase. And so is there a standard there for somebody who's not a surgeon, or a patient who obviously doesn't know the implications of risk? Is there a certain amount of time from this point forward that we want to see cases get done with a certain amount of time, and if we can, because obviously some cases can take a super long time, and you have to just deal with that because of how invasive it is. But is the fact that you are restricted on what you can use, and that puts a direct correlation to the amount of, you're doubling the time it takes to do a case, that affects infection risk. Can you talk through that specific piece of it as far as the
Well,
simplicity of this much time more could cause more problems?
so that it's not really that there's a specific amount of time, right? But it's more of there's a curve. The longer that you're in surgery, the higher the risk you are of getting an infection. And so, if you're in surgery for 40 minutes or 20 minutes or 80 minutes, that amount of time increases your risk. Now, if you have the equipment and tools to be able to do something faster and more efficiently, I think that generally is going to be a win for everybody involved, whether it's the surgeon who's, spending a lot of time trying to get these cases done efficiently, or the patient who's, open and available to their wound is open to air. And then finally, even the hospital would actually benefit from this. But again, because the costs are somewhat hidden, it's hard for them many times to measure those indirect costs. And, a famous quote that I've heard is, there is no such thing as a good slow surgeon, right? And what I mean is, it's not that you want to be inefficient, or it's not that you want to be fast or rushed, but you just won't want to be under the knife for a long period of time for something that should be done with relative efficiency.
Yeah, that makes sense. So that gives a good picture, I think, into your world. You got two worlds. One world, you get to decide what technology, what tools, what implants that you want to use, because you as a group, you are in control. And then you have another side that is limiting you to potentially two choices. In some places, for others, it's worse than that. They get to work with the third, fourth option. Is there anything else that you've seen along the way that is a bigger problem of doctors' voice being taken away, or that's preventing them from being able to be really truly in the best interest of the patient?
I think bigger than implant choices and hospital decision making is actually that we are all essentially working for insurance companies. The insurance companies are what make decisions for all of us, and they also determine the pay rates for physicians. And so, Hawaii has a pretty significant physician shortage, even though we're in one of the most beautiful places in the world. And the big reason is that we have some of the lowest reimbursement rates in the nation, with one of the highest cost of living areas in the nation. And you would think, okay, well, maybe they would allow for some improvements with some competition. But essentially, what happens is that the hospitals will employ physicians and pay a higher rate, whereas the private practice physicians will find that you're stuck as a small entity trying to negotiate with insurance companies, and the insurance companies may or may not increase their pay rate towards you, and so you become invested in things like surgical centers where you're trying to negotiate for improvements in the facility fees, because with the way that Medicare has been trending is they've been decreasing the reimbursements to physicians while simultaneously increasing the reimbursements towards facility fees. And facility fees are things, reimbursements towards places such as hospitals, surgery centers. And unfortunately, a lot of times you have to, these surgical centers are partnered with either hospitals or management companies and take a pretty significant cut of those surgical fees. And so, just to maintain a physician salary, which has been reduced on where the reimbursements have been reduced on an annual basis, there is this constant struggle where physicians are trying to figure out ways to recoup what would be their losses every year through things like facility fees. And there's because of the increased costs of nurses' salaries are going up, the staff salaries, the space, just having proper leases go up every year. And so whereas reimbursements don't follow that increased cost. And so what I see is that the hospitals and the hospitals and insurance companies, at least in my state, are some of the most profitable companies, whereas private practice and physician reimbursements continue to follow this somewhat downward trend relative to inflation. And it's one of the few places one of the few economies in the US where our what we get paid is not linked to the market rate. It's really linked to whatever the government's decided.
And what, in your mind, as the one who has to deal with the fallout of this, is there any justification for why it's acceptable that doctors are the only ones getting cut and everybody else is getting increases?
If everybody else was sharing in that same risk, risk meaning if there's a problem, right? Say the wrong medication was given by a nurse, or a weaker a weaker assistant during surgery for a hard case was placed during that surgery. It doesn't matter, because as captain of the ship, the surgeon is always the one who's ultimately responsible for all these problems. And so, we have the liability with our insurance companies. We've essentially assumed liability from the patient standpoint,
Sure.
but the control is not entirely in our hands.
I know, but I'm just wondering, as a body of professionals,
Mm-hmm.
is there ultimately, as the leader, the buck stops with the leader.
Correct.
The entirety of the outcome in anything, yes, the teammate on the team might have done something, but the leader steps up and takes the responsibility for the whole team. I get that. So I can see how that's the case as a surgeon. But could you conjure up any other potential justification that's truly legitimate, though? So why, if nurses aren't getting cut, if hospitals are not getting cut, if everybody else, every other stakeholder that's a part of the ecosystem for healthcare is not getting cut, except for the physician, the doctor, the surgeon, is there any legitimate justification for that? Other than they just don't do anything about it. They just take it.
I think the biggest thing is that physicians are the easiest target, because we do have societies where we've joined different societies as a collection. I think physicians as a whole tend to be more competitive with each other, as opposed to joining together and forming a union and trying to work out a deal with insurance companies to make sure that we maintain what we're supposed to be getting paid. Instead, what ends up happening is we tend to complain about it and tend to accept what's being given towards us, as opposed to making the changes that need to be made.
Paul, in your mind, what's something simple? You go to these society meetings and people are complaining, but nothing happens. In your mind, what are some simple things that you can do to change what's going on right now? Instead of just complaining, what's something you can put into action that would actually yield results?
Well, honestly, I don't really have a great answer for that, right? I mean, in this state, for example, there was a recent strike by the nurses, in one of the hospitals, and I think right now another hospital is threatening to strike, where they basically walked out and there were no nurses within the hospital, and they essentially had to hire locum nurses to come in and cover. I think you could do that to some degree in hospitals. The issue is that there's so many different directions that all these different physicians are being pulled in, whether they're private practice or employed physicians, that even if all the employed physicians decided to walk out, they would still have enough hungry private practice physicians that would come in and kind of take in that
Bail 'em
same
out.
area.
Yep.
Yes. And so I don't think I don't think that physicians are collected and I think that the best thing is if we could come together and actually agree that, hey, this isn't working for us. Enough is enough, and that we've got to demand that our government increases what Medicare is paying every year to physicians as opposed to hospitals.
Anybody listening to this podcast,
Yep.
I want you to hear that Paul said he doesn't have a good answer, but came up with a really good answer.
Sure did.
And that answer is you have to band together. Even if it's 25 docs in your local area or even your state, you can get things done. How do people get together? Reach out to DocNation. We can help coordinate that. Doesn't matter
That's
where.
exactly what you kicked off the conversation with, is helping you organize. If union is scary for you or striking sounds to be too extreme, that's okay.
We can negotiate with the hospitals a plan. We'll give you
Yes.
90 days. We're going to continue in this miserable situation for 90 days, but you have to change this, this, and this. Because the truth is, we want to be as least combative as possible with the decision makers. But at some point, changes have to be made. When the nurses left, Paul, that was okay. I might get hated on by all nurses in the country, but here's the truth. You can run a hospital with all doctors. You cannot run a hospital with all nurses. You could realistically replace all the nurses with doctors, and healthcare not only stays the same, but increases. You cannot do that vice versa. So there's a moral obligation that you guys have that nurses don't. And that's the line in the sand that insurance companies, that administration, that all the decision makers know that you won't cross. So if you come to DocNation, we will help you. Even if you're a single doc and you're saying, hey, I want to find 5 or 10 around me that are having, because everyone's having the same issue, we can help coordinate that. Okay, Paul. So I'm saying that to you right now. Maybe we ought to have a meeting offline to say, is there anybody around you that you can reach out to, that we can reach out to, and we'll put a plan in place to see if we can't get some changes made. It's happening around the country in small pockets. It's just not happening enough, and it's not happening at scale because of what you just said right there. I don't know how to get everybody together. That's something that we'll do for you.
Yeah, you made that great point, Paul, about the societies. They kind of burrow their own little section and they kind of keep themselves. They don't necessarily say, okay, I'm going to do an alliance with this group and that group, and we're going to all collectively align. We may disagree on some of the things that are below the line, but at this level, we have to agree that our voice needs to be respected. And there's so much we can do that isn't all the way to the end, which is not showing up to work. Because we hear the concern, well, if you do that, then emergencies and people's lives that are at risk, like, are you going to really just walk out on patients that are dying? No, we're not going to do that. But there's enough other non-critical care related stuff that departments and things that could all be delayed and reorganized and rescheduled and all that to do what actually the patient needs. We need some short-term pain to be experienced in the flow of medicine to get to better outcomes long-term. If we are in a situation today where we have the most knowledge, the most research, the most technology, the most of everything, we're the most advanced that we've ever been in society and healthcare, but yet we have the worst health crisis ever. Those things don't fit. They don't go together. They're exactly opposite of each other.
100%. 100%.
It doesn't make sense. It's insane that we have the most of everything and the worst of outcomes. Well, what got in the way? What caused this divide to happen? It's the doctor and the patient used to be like this, and now they're like this. It's because of third parties calling the shots. And so we need to have these conversations. Contracts need to be renegotiated. how about we get the entire state of Hawaii to have all of their insurance contracts renegotiated? Guess what? We have a team for that. Did you know that every single CPT code, what they're worth for every single provider, practitioner, surgeon in the nation is publicly available? It's just hard to get to. We're talking way beyond the scale of all the data that's in the Library of Congress. It's a ton of information that has to get extracted by tools. We have an entire team dedicated to be able to extract that data and give it to every single doctor so that way they know what I'm actually worth and what I should be getting paid anywhere and everywhere. Why don't we get the entire state of Hawaii get their contracts renegotiated? Because if reimbursements are so bad, it's one of the lower states. That makes no sense. That's bad for patients. As a nation, like, why don't we have people in DC championing this to say we need, is Hawaii not, are the citizens of Hawaii not as important as our other states? Like, think about how strategic Hawaii is as a state for our country. Strategically, it's one of the most important states.
Right.
The most important states. And yet the quality of care is at risk because we can't get doctors there and we can't pay them right. Like, this should be a national priority that we have. This is an easy fix. The conversation just needs to happen. It should be happening now, and there should be action taken. So, Paul, thanks for jumping on the show with us and highlighting and underscoring this problem, because it's a major problem. It's a national security risk, actually. If you think about it, we don't have the care that we need for the right people, for our people on the islands. That doesn't work. We need it for the sake of defense for our country.
Well said. Well said, Justin. Paul, it's early there for you. What time is it there?
It's about 7 o'clock in the morning.
7 o'clock. So you were up 5:30, ready to rock and roll to join us. So thank you for doing that, Paul.
Not only that, he had some stuff going on yesterday, and not that he needs to share it, but
Well, it's okay. I just had appendicitis. I had an appendectomy yesterday morning, so I'm just recovering from surgery.
That's
bounces back like it's nothing.
That's the quality of people that physicians are. You're just givers. You serve, and that's part of the problem. Is that you guys are not as combative, not as much of fighters in terms of negotiating contracts and doing things that take care of you individually. But thank you for joining us, Paul. We really appreciate your time, man.
Nice to talk to both of you, Reid and Justin.
Have a great day.
You as well. Bye.
This has been the DocNation Podcast. If you like what you heard, be sure to subscribe, rate, and leave us a review on Apple Podcasts, Spotify, or wherever you are listening to us. Your feedback really helps us reach more listeners like you. We'd also love to hear your thoughts and any topics you'd like us to cover in future episodes. Don't forget to follow us on Facebook, Instagram, and LinkedIn for updates, behind-the-scenes content, and to join the conversation. Thanks for listening.